Welcome to this webinar of the Chest Council of India, the CCI as we know it affectionately. Today's webinar deals with the role of 2D echo and catheterization in the right heart with respect to pulmonary medicine. After all, most of us listening in here are pulmonologists and physicians with a special interest in pulmonology. And unfortunately, we find that very often in echocardiography, the right heart is neglected, and we often get very sketchy information. And yet, we know the heart and the lungs are very closely intertwined. The heart affects the lungs, and vice versa, the lungs affect the heart. And it's surprising that we have not come closer together in our assessment of this very important set of organs. So today we have some excellent speakers. Dr. Nitin Abhyankar needs no introduction to this group. You all have heard him very often before. He's an MD medicine like me, and then later, of his love for for pulmonology that both of us share, did his training in pulmonology, got a European diploma in adult respiratory medicine, and is a practicing chest physician and bronchoscopist. He's also, I always fondly recall, a great friend for many years, and has helped us set up our thoracoscopy program at Narayana. So, Nitin, welcome. Dr. Nitin Abhyankar is going to be talking about the role of 2D echo here. And we thought it's wise to get a pulmonologist to talk about it because he'll be talking about things that are of interest to us. But we also have an excellent expert in echocardiography, Dr. Satish Govind. He's a DNB, a fellow in non-invasive cardiology, a PhD, and a fellow of the American Society of Echocardiography. He's our chief of non-invasive cardiology at Narayana Health City in Bangalore, and is my go-to person. Whenever I have a problem with non-invasive cardiology, the person I always approach is Dr. Satish Govind, and he's never, ever let me down. He also happens to head our ethics committee, so that's a solid combination, non-invasive cardiology ethics, and drives a lot of the research at Narayana. So he'll be taking up a lot of the questions that come up in the panel, and I'm sure there will be a lot for him. Our third speaker is Dr. Jagdish Hiremath. As his name tells you, he's probably from Karnataka originally, but is now the director of the Cath lab at Ruby Hall Clinic, Pune. He is the HOD of the heart transplant department, a very difficult area, as you all know, a DM in cardiology, a DNB in cardiology, and the fellow of the American College of Cardiology. Highly qualified, an excellent speaker, and a good friend to Dr. Nitin, who, I think will tell you that he's one of the finest cardiologists he knows. So with no further ado, I will invite Dr. Nitin Abhyankar to talk to us about the role of echocardiography in assessing the right heart, which Dr. Satish Govind just told me is often called the forgotten heart. So over to Dr. Nitin Abhyankar.
Thank you very much, Dr. Murali, for your very kind words. I will start the presentation by sharing the screen. I'm going to talk to you in the next few minutes about the importance of 2D echo from the viewpoint of a pulmonologist. Echocardiography, as we all know, is one of the most important tests every pulmonologist must be asking for. But sadly and historically, the right ventricle has received very much less attention as to its counterpart, which is the typical popular left side of the heart. Yet there is a substantial body of evidence which tells us that right ventricular size and function are equally important for the prognosis of patients in various forms of heart-related and pulmonary diseases. RV dysfunction is associated with excessive mortality in various cardiac conditions that is already known. In addition, things which are relevant to pulmonologists like pulmonary embolism and pulmonary arterial hypertension also, RV dysfunction is associated with excessive morbidity and mortality, worth keeping in mind. If you look at the normal anatomy, the right atrium and the inlet, as we call it, will pump it into the right ventricle, and eventually the right ventricular tract through the pulmonic wall will push it to the pulmonary artery. If there is no septal defect, then there is no, generally the volumes on both the sides, that is the stroke volumes, are equal, though the right side is of course a much low pressure system. If we look at RV in the terms of a shape, it is like a pyramid, which has that typical inlet we talked about. Then this is the body of it, and this will be the outflow tract, basically. Essentially, the contraction of the RV is caused by the longitudinal fibers, which shorten, and the superficial layer of circumferential fiber, which cause the inward thickening. RV typically lacks a third layer of spiral fibers, which is actually present in the left ventricle, but it is absent in the right ventricle. Some of the descriptive findings which look like an abnormal right ventricle include a RV cavity, which appears as large as left ventricle. If it starts looking as large as, which is much smaller than the normal height, then it suggests a moderate dilatation. If it looks larger than the left ventricle, then it is a severe dilatation. And if it is forming the apex, once again, it is suggestive of significant dilatation. So that's how you look at these things. But these are not numericals, and we have to come to specific numericals which can make or break a particular advantage or disadvantage for the RV2D echograph. And the first of these dimensions come from apical four-chamber view, which is about the RA area. And now we will be seeing this in a little bit of a detail. So what we are looking at essentially is, the view is typical apical four-chamber. The timing is naturally end systole, where the RA is fully filled, and in the longitudinal or a major axis dimension, it should be less than or equal to 5.3 centimeters, and in the minor axis, it should be less than, or the horizontal axis, it should be less than 4.4 centimeters in the length. Now, if you look at primary pulmonary hypertension, followed for about 37 months, RA area index to height was one of the only two echocardiographic predictors of mortality. So the RA size matters. Even in chronic systolic failure, RA volume index to body surface area was found to be predictive of mortality, need for heart transplantation, and hospitalization for heart failure. More importantly, atrial fibrillation and flutter, which are essentially products of the RA size, and RA enlargement will be typically more associated with it. So once again, the RA size matters. So that's an important parameter. Now we come to the right ventricle, and the right ventricle typically apical four-chamber view. This is the size of the right ventricle, and the normal reference limits for the right end diastolic. Naturally, the ventricle will be estimated in the end diastolic phase, where it is less than 24 centimeters squared in men and less than or equal to 20 centimeters squared in women. These are the values. How clinically relevant is the RV size? If it is studied, one of the studies which looked at moderate to severe chronic pulmonary disease, where the right basal diameter of the RV, which was measured at end diastole and indexed to the BSA, was obtained in 92% and was most significant predictor of mortality over a follow-up period of 16 months. In another series of acute pulmonary embolism patients, relative RV enlargement suggested by the RV to LV end diastolic diameter ratio of more than 0.9 was predictive of in-hospital mortality and was useful in identifying with patients who require more aggressive therapy. So once again, the RV size also matters. In the context of tricuspid regurgitation, which is actually a functional phenomenon, so it's a functional tricuspid regurgitation in absence of an organic tricuspid valve pathology. This is typically seen in patients who have chronic RV pressure overload or RV enlargement, or more specifically dilatation of the basilar annular portion of the right ventricle. And this is also relevant to our context. So the RV size also matters. Now, can we get it wrong when we are measuring a RV size? This is the typical proper tracing which takes care of all the trabeculations. This is where non-compacted trabeculations have not been included by the person who's recording it, and therefore he's underestimating the RV size. This is where the apex has been excluded by the interpreter, and therefore he's underestimating it. And this is where he's grossly overestimating, because instead of the apical four-chamber view, he is using an RV modified view with medial placement of the transducer, and therefore the RV looks much larger than what it is actually, and therefore you are overestimating it. The typical two common errors which are done when you are looking at the RV linear dimensions, one of them is, of course, acquiring a non-optimized four-chamber view, which results in underestimation of the RV. And the second one, which we already saw, acquiring RV modified apical chamber view as opposed to RV focused apical chamber four-chamber view, that will lead to the overestimation of the RV size. So that's how you have to avoid these errors when we are measuring. Therefore, it is a very important critical thing to obtain a well-aligned RV focused apical four-chamber view. This is accomplished by ensuring that the transducer is positioned over the apex of the heart, not over the body of the RV, as in RV modified apical four-chamber view. And then the appropriate tilt is given to get the maximum RV dimension in the plane. Right ventricular outflow tract can be looked at the proximal and the distal levels, and we will see the relevance of that in the terms of RV hypertrophy diagnosis. If I'm looking for RV hypertrophy, I look at it in all the three views. That is, RVOT in the parasternal view, RV free wall is looked at in the apical four-chamber view, and inferior or diaphragmatic part of the RV is looked at in the subcostal view. Generally, the RV free wall thickness, which is usually 3 to 4 millimeters, if it exceeds 5 millimeters, then it is considered hypertrophied. Now look at something which is very commonly reported to all of us, which is a 2D echo finding of a severe pulmonary arterial hypertension. There is a severe hypertrophy of the RV wall on both the sides. There is a dilated RV chamber, right ventricular chamber has become bigger. There is a hypertrophy of the right side of the septum. The right side of the septum has become hypertrophied. The septum is essentially a flattened one because of the overload in the RV, and the LV typically looks what is called as a D-shaped LV, which is, these are the classical findings of a severe pulmonary hypertension patient with a 2D echo, who is undergoing a 2D echo. We now move from the dimensions to the functional parameters, and one of the first functional parameters I will talk about is TAPSE, which is tricuspid annular plane systolic excursion, which is very, very important, considered to be very important for the functional assessment. And this is typically done in a mode which will be essentially apical four-chamber again, and placing the M mode cursor on the lateral tricuspid annulus, measuring the peak distance which is traveled by this annulus during the systole. And more it travels during the systole, better is the RV function. The normal reference values for this typically for TAPSE is more than or equal to 1.7 centimeters. Now, what are the limitations? The primary limitation of a TAPSE is only representing one component of the RV motion with one single segment of the RV myocardium. It's not taking the total picture. Sometimes RV may be frankly dysfunctional despite relatively preserved TAPSE. That can happen in pulmonary arterial hypertension, and typically after a cardiac surgery, the RV function may be globally preserved despite a significantly reduced TAPSE because the wall is involved in that. Another potential limitation of TAPSE is directly proportional to and therefore influenced by the RV size. So the larger the RV, you are going to get readings which are not so correct. The common errors while measuring TAPSE are not placing the M mode cursor parallel to the plane of longitudinal motion, which will result in angle-dependent underestimation of TAPSE, and sometimes incorrectly measuring the magnitude of the displacement from the M mode image. TAPSE still will reflect right ventricular function with a very good clinical utility, particularly for the pulmonologist in the precapillary pulmonary hypertension. It is supposed to correlate with the CMR derived RV ejection fraction, and it will predict long-term mortality. Also, as we are familiar with, inferior myocardial infarction, reduced TAPSE is found to be an indicator of a RV infarction, even if there is no regional wall motion abnormalities which could be identified. In the other measurement, which is of important, which is called S prime or tricuspid annular velocity. We are looking at the longitudinal velocity of the tricuspid annulus during the systole, at what speed it is moving. And this is again obtained in apical 4-chamber view. And the peak velocity of this particular point, which is the lateral tricuspid annulus, is measured during systole. The care is taken not to measure the peak of ejection waveform and not the earlier isovolumetric contraction waveform. Greater the velocity, better is the RV function, and the typical value for S prime is supposed to be equal to or more than 9.5 centimeters per second. So that is about the tricuspid annular velocity, and this is how it gets measured. It is relevant from a pulmonologist point of view that it is again correlating with the CMR-derived right ventricular ejection fraction, and it predicts outcome in patients, particularly with pulmonary hypertension, as well as inferior myocardial infarction, chronic heart failure, etc. The fractional area change is sort of an equivalent of a RV ejection fraction, and where the systolic, end diastolic and end systolic volumes are estimated. This is typically a 60% ejection fraction or a fractional area change. This is typically a 40%, so the relatively less change in the diameters. And this is typically a badly failed right ventricle, which is showing a functional area change of only 20%. So that's how we look at it. We come to the next important parameter, which is myocardial performance index. And this is typically picked up between the tricuspid closure to opening time, which is again estimated on the M mode echo, and minus the ejection time, which is again estimated here, and then divided by the ejection time. And MPI is an excellent measure of the performance. This is typically done in a pulse wave Doppler to perform the myocardial performance index. And the unique advantage of myocardial performance index is that it is a very sensitive parameter to be affected earlier, before the other functional parameters, and an early RV dysfunction can be picked up by this. Secondly, since MPI is non-geometric in nature and relies solely on the time intervals to derive the measure of RV function, it is useful to evaluate an RV which is oddly shaped or poorly visualized. Even in those situations, this comes to our rescue. So MPI is a useful functional parameter worth looking at. What is the usefulness? It also has a prognostic value just as TAPSE, S prime, or FAC have in variety of clinical conditions. One of them, of course, includes pulmonary arterial hypertension or a chronic thromboembolic disease, or even patients who are about to undergo a coronary artery bypass surgery or a valvular heart replacement surgery. Abnormal RV MPI is associated as an independent risk factor of postoperative mortality and major morbidity. So it's worth keeping in mind. We come to the last part and the most important part of our talk is hemodynamics. And in terms of hemodynamics, RA pressure is useful, particularly in the critical care scenario where it's an indicator of the volume status and the responsiveness to fluid challenge in the critically ill patients. It's also useful as a diagnostic sign in patients with suspected cardiac tamponade or other pericardial syndromes, and as a part of echocardiographic estimation of pulmonary artery pressure, so RVSP, which we'll eventually see next. So pulmonary arterial systolic pressure or right ventricular systolic pressure is 4 into peak tricuspid regurgitation velocity plus right atrial pressure. So that will be the pulmonary arterial pressure. Now, in order to get them, all we have to do or make sure is that we are looking at the TR jet in multiple views, and TR velocity is measured in the accurately peak TR velocity using the ductal spectral recording from the position most closely aligned with the J is very important. It is critical to minimize the angle of incidence of the cursor to the flow to less than 40% to avoid underestimating a tricuspid regurgitation velocity or TRV, adjusting sweep time between 75 to 150 milliseconds, and avoiding non-representative beats. That is very important, particularly in a patient who has arrhythmias. So I think that is important. And this is the way it gets measured. And a full envelope is what is a complete or a partial envelope, but the signal must be at least interpretable. And then there are some additional tricks, and looking at the IVC collapsibility also matters. So in general, echocardiographically estimated pulmonary arterial systolic pressure exceeding 35 in younger adults or 40 millimeters of mercury in older adults, which are more than 60, should be considered elevated, particularly if they are being evaluated for dyspnea. Now, to come to the end of my talk, I'll be concluding with some few take-homes that RV interpretation should not anymore get limited to the only idea of right ventricular and left ventricular moderately dilated or something like that. It should look at chamber dimensions. It should look at evaluation of the right ventricular systolic function and estimation of hemodynamic parameters. All should be routinely performed. The typical, whenever feasible, all these parameters should be reported. RV basal diameter, which should be equivalent to less than or equivalent to 4.1 centimeter. If feasible, RV volume with a 3D acquisition, which is not currently being practiced. RV volume from apical 4-chamber view using a single plane Simpson's method. RA pressure should be estimated, including as well as the inferior vena cava size and collapse should be estimated, and pulmonary arterial systolic pressure should be reported. The RV systolic function is reported in at least one of these quantitative parameters. Tricuspid annular plane systolic excursion, we have already seen TAPSE should be more than 1.7 centimeters. Tricuspid annular velocity or S prime, which should be or equivalent to or more than 9.5 centimeters per second. Fractional area change should be at least 35%, preferably more than 40%. And myocardial performance index should be, if done on a pulse Doppler, it should be less than or equal to 0.43 and less than or equal to 0.55 if I'm using a tissue Doppler. I'm sure I have created enough curiosity in your minds about a pulmonologist looking at a right side of the 2D echo with a greater curiosity, and I am sure our stalwart cardiologist panel will be answering a lot of these questions which I have raised in this small presentation of mine. With that, thank you very much for your patient listening.
Good evening. For today's second talk, we had a brilliant deliberation by Dr. Nitin Abhyankar. I'm sure it was a new field for him, a pulmonologist talking about echoes. But here I am in my own backyard, that is a right heart catheterization for, of course, for pulmonary medicine that we'll see. That's me with the blue arrow here, working in the cath lab. Of course, this is some other procedure, not right heart catheterization. And as you are aware, not many right heart catheterization take place in the country as such related to pulmonary medicine. And the wariness, I don't know why it is, the actual fear may be so much, and the hula-boo related to that is so much, because somehow we have not dwelled into it longer, or somehow we have not gotten our thought processes right about the right heart catheters. I'm not a big fan of right heart catheters, but let's unfold things as they are right now. See, the indications for a pulmonary medicine right heart catheterization, of course, mainly comes from pulmonary hypertension. Once a pulmonary hypertension is diagnosed either by echo or some other means, to ascertain pulmonary hypertension vis-a-vis the systemic blood pressure is what is the main job of a right heart catheterization. You know that pulmonary arterial pressure cannot be diagnosed by easy means like a cuff on the arm. It can be diagnosed by echocardiography, but it will have its own limitations. So the only way, the best way to record a pulmonary artery pressure is to enter the pulmonary artery. And that's why you have to enter it through the right ventricle, right atrium, and that's why it's called as a right heart catheterization. Once you do that, check the pressures, check the oximeters, we can check the reactivity That means if you have a established pulmonary hypertension, whether it is vasoreactive or not, may it be for nitric oxide, may it be for, we use milrinone many times for heart transplant patients, then IV epoprostenol or adenosine can be used to see whether this reactivity is existent or not, or it's a fixed change of the pulmonary vasculature. Sometimes to check right to left shunt or left to right shunt based on the oximeters, then you can check, of course, on calculate the vascular resistances, cardiac output, systemic vascular resistance also if the left heart is done. And of course, the sidedness of pulmonary hypertension. Sometimes it could be left-sided, veno-occlusive, or say mitral stenosis or LV dysfunction, or it is a pure right heart problem, or it's a mixed problem. All this information is extremely important. And of course, to quantify the chronic pulmonary thromboembolic disease, which is a big indication nowadays because the surgery is a cure, we need to know definitely much more about right heart catheterization than we know now. I don't want you to go through the slide, but the European Society of Respiratory Medicine doesn't give you 1A for anything, whether it is right heart, whether vasoreactivity, all these so-called indications. Actually, it is 1C, 2B, 2A, 2C. So it's not a 100% indicated procedure, but there are instances where it needs to be performed very definitively. And the vasoreactivity that I was talking about, actually, it is not practiced so much in the world as such, hardly anywhere in India, but you don't have to do contraindicated things like giving high dose calcium channel blocker and check whether vasoreactivity or not. You just have to check it with other things like adenosine, nitric oxide, which I mentioned. Coming to the procedure proper, it is of course done in a cath lab. It could be bedside procedure in the future as time goes by. The femoral vein is cannulated, right or left, under local anesthesia. Then radial artery can be used to enter into the left ventricle, but we are talking of pure right heart catheter today. So from the femoral vein, it goes to inferior vena cava. The catheter is under fluoroscopic control, enter right atrium, through the tricuspid valve, enter the right ventricle, through the pulmonary valve, enter the pulmonary artery, and then deep down, once you record pressure inside the pulmonary artery as the catheter reaches right at the periphery, it will record pulmonary capillary wedge pressure. In turn, it is recording the left atrial mean pressure, and in turn, it is recording the left ventricular end diastolic pressure. So if the readings are well done, catheters are well flushed, and pressure monitorings are done very well, you can get all pressures of all the chambers that you have entered, including indirectly the the left ventricular end diastolic pressure and the LA mean pressure. One can use a Swan-Ganz or a flow-tipped catheter to enter the pulmonary artery, but it is expensive. So most of the times we use normal catheters with a bird's eye or end hole. So how it is done? This is my own my own hand drawing, so it is a bit shabby. Pardon me for that. Through the inferior vena cava, through the right atrium, tricuspid valve, RV, pulmonary valve, pulmonary artery, and if it is balloon tipped, it will go anywhere, or you can maneuver it, and then you go right at the periphery where you record the end of the pressure, end of the catheter pressure, which is PCW, pulmonary capillary wedge pressure, in turn talking of left ventricular end diastolic pressure. Then when you are enter inside, you record pressures, the oximeters in every chamber. Hemodynamic challenges can be given if required at this stage. Then repeat the pressures and oximeter in various chambers. And then of course, after the procedure, just a venous pressure compression for some time. Patient is sent to ward. And nowadays we don't use any antibiotic for this procedure. Again, my own shabby handwriting or drawing. The right atrial pressure is ACV, as we see in the jugular venous pressure. So it would be 3 waves, low down, close to the 0, or maybe 7 or 8 millimeters of mercury. Then right ventricular pressure touches 0 in diastole. So this is recognized as right ventricular pressure. As you enter the pulmonary artery, the systolic will be equal to right ventricular pressure, but the diastolic is not 0. So this is arterial trace like a pulmonary artery. And then when you enter the pulmonary capillary wedge, again it starts ACV because it is now recording the left atrial pressure and also the end diastolic pressure. So these are the pressure waveforms I'm sure so many of you must be familiar with also. The information obtained is the pressures of all chambers and their interventions, whatever are required. Pulmonary vascular resistance in Wood units, systemic vascular resistance if left is done. Then you can calculate cardiac output, can intracardiac shunts, reactivity of the pulmonary artery pressures, and if a pulmonary angiogram is done, you can look at the thrombi, the pruning of the arteries, and of course, record the tricuspid regurgitation, if at all. We have to think of complications because finally it is an intervention. Fortunately, the morbidity and mortality is less than 1%. There could be perforations in the right atrium, right ventricle, PA. Right ventricular perforations are forgiving because the right ventricle is highly trabeculous and it can seal off on its own. But the RA and PA can land you in troubles and tamponades. While entering the right ventricle through the right atrium, it can result into right ventricular tachycardia, or you can get SVT-AF when you are in the right atrium. There are patients who are very high pulmonary artery pressure. Even entry of the catheter in the PA can cause severe vasoconstriction of the pulmonary arteries, leading to hemodynamic collapse. Fortunately, these things are now less than anecdotal. If you use a contrast medium, it could result into contrast-induced nephropathy, and it could be related to procedural-related infections and groin complications like any other intervention through the groin. What could be the possible drawbacks once you do a right heart catheter? Fortunately, they are not great. You may not be able to enter the right ventricle at all because there is so much hypertensive tricuspid regurg. The catheter keeps bouncing back, and even the flow-directed catheter bounces back into the right atrium, cannot enter. Patient cannot lie down for a long time because they are all sick patients. There could be inadequate recording of the pulmonary capillary wedge pressure because if your PA pressures are very high, getting right into the periphery and recording the pulmonary capillary wedge pressure can be a problem. And of course, sometimes a de novo without oxygen PA pressure may not be able to record because the patient may require oxygen continuously during the procedure. See, these are all hemodynamic pressures, including the right heart pressure, and they are direct pressure. They are not calculated pressure, but hemodynamics can vary with various loading conditions. Patient is dehydrated, is given a diuretic in the morning, is very anxious, or too deeply sedated. All these things can make a difference in the hemodynamics. Echo lab is friendlier. It's not so intimidating. So pressures there could be different as into the cath lab. But if they are within 10 millimeter, they are considered almost on par with equal. Then why is the right heart catheter considered a gold standard for ascertaining pulmonary hypertension and related studies? Because they are actual measurements of pressure. They are not derived as we derive from in echoes. It does not depend on the patient breathing, ventilator, or emphysematous chest obstructing the echo views, an obese person not giving very good echo signals, tricuspid regurg hardly there, so you cannot calculate pulmonary artery pressure, or the collapsibility of the IVC can vary based on the diuresis and all. So echo can have problems. Whereas cardiac output, pulmonary capillary wedge pressure, for that matter, LVEDP, all these are domains of the right heart invasive catheterization. They are not echo domains. Echo information exclusive is more anatomical, right? The right atrium, right ventricle dimensions, flat interventricular septum, right ventricular function, TR assessment, PR assessment. These are all domains of echocardiography. However, calculation of pulmonary vascular resistance, cardiac output, left atrial pressure, they're all derived from echoes. I'm going to show you some equations. Look at that. RV pressure is a derivation. right atrial pressure, mean arterial pressure, PVR, LVADP are all complex equations derived from echo, whereas in the right heart catheter, it's a direct, and that's why it is a gold standard as compared to echo. However, once we talk of the practical adaptations of right heart catheter in India, I would say cath lab facilities, cost involved, small but sure morbidity and mortality due to the intervention are all these things we have to consider. For first assessment, somebody's PAH is getting diagnosed for the first time. Probably it will be important to do a right heart catheter. And of course, bigger decisions like the treatment modalities, the organ transplants, it seems a must to do a right heart catheter. For research, publications, tertiary care hospital, suppose a patient now Narayan Rognala, we know do so many of these pulmonary endarterectomies for chronic thromboembolism, the pulmonary arteries. Once a patient goes there, necessarily they have to do the right heart catheterization. Echo, I feel, is terrific for its cost effectiveness. It's a benign thing. It can be done anywhere. Its application is so benign. So it's wonderful for the masses, and especially for follow-up. I feel that after the initial evaluation and the treatment modality decided, follow-up on OPD basis can be wonderful with echoes. As if actually it's comparing a BMW SUV with a kinetic two-wheeler. Kinetic two-wheeler has its own application in India. We cannot forget that. But we know that BMW SUV obviously is the state-of-the-art thing. So the right heart catheter actually is a road less traveled for various reasons, unfortunately also. But as I said, for important things, it needs to be trodden this led. Probably it is left for the tertiary centers and bigger centers to do it when it comes to critical decision making. But for the masses and individuals like me, quite happy to follow up patients on echocardiography. I hope this gives you a fair idea of what right heart catheterization is and means for a pulmonologist. Thank you very much.
Thank you so much. So Dr. Hiremath, Dr. Abhyankar, those were two excellent talks, summarized exactly what a pulmonologist needs to know. It's the beginning of our journey into these two areas. Most of us are not very knowledgeable about echocardiography itself. So let's spend the next 1 hour or so looking into these in greater details and how we can understand better what are the benefits, what are the drawbacks of this. First of all, I think Dr. Hiremath needs to leave fairly early. So I'd like to really start with his questions. And there are also a lot of questions coming in already. My colleague from Narayan Hridayalaya, Dr. Basha Khan, who heads our lung transplant and does a lot of our work with pulmonary and endarterectomy preparation of the patient. He's a fellow pulmonologist. He asks, and this question should go to Dr. Hiremath, sir, please elaborate the pros and cons of the fix versus the thermodilution technique for cardiac output.
I saw that in the chat box. I don't think I can answer this question. Maybe Dr. Satish can help me.
No, I think I'll leave it to you. I'm also not very...
No, I don't do it, so I don't know.
Okay. What do you usually use, sir? You use the FIC, is it, or the thermodilution?
FIC.
FIC itself. Okay. Right. I have no idea either, Dr. Basha. I'm sorry, I can't help. The other question that I wanted to ask you, Dr. Hiremath, we always worry about the complication rate. You mentioned some of the potential complications. How often have you actually seen any of these complications? But you used a very interesting term, I noticed. You said less than anecdotal.
Yes.
So can you explain, how often you've seen these and whether we really should be worried when we refer a patient for a right heart cath? And what do you tell the patients before you do a right heart cath?
No, I think it is perfectly safe. As I said, in maybe 30 years of my practice, right heart, I must have faced complications in 1 or 2. So, and the books also mention less than 0.5. So the complication rates are very few. But when they occur, they are terrible because many of these patients are sick patients and they won't tolerate hemodynamic alterations very well, especially the severe pulmonary artery hypertension patients. So the counseling for the patient is, it's an extremely safe process, and complications would be anecdotal or like it can occur in maybe a tonsillectomy or maybe a penicillin injection. So that kind of advice I give to them.
And for our fellow pulmonologists, you know that even bronchoscopies, simple diagnostic bronchoscopy, carries a small but definite risk. And certainly when we venture into transbronchial lung biopsies and cryo lung biopsies, again, small, not a reason not to do them, but do carry a certain risk. So I think we need to take that on board when we ask for these procedures. My suggestion would be have a good relationship with your fellow cardiologist, speak to him, and by and large, most of them are used to doing it these days and will not turn you down. We certainly are not having much of a problem at Narayana, especially in the last 3 or 4 years. It's been done routinely, as Dr. Hiremath said, for all our CTEF patients, the one with chronic thromboembolic pulmonary hypertension, and even for others. And remember that when a cardiac catheterization is done, as Dr. Hiremath has already said, they look at the pulmonary capillary wedge pressure, but they also at the same time, especially if surgery is planned, any kind of surgery, is also do a coronary angiogram, which is essential. And they may even do a renal artery shoot to make sure there's no renal artery stenosis. So, one procedure with its extensions, you get a lot more information. So it's something we should not be turning down and shying away from. But yet with all this information, Dr. Hiremath, why is this modality underutilized?
The information obtained actually doesn't convert into practical importance. That's one way. So suppose somebody diagnoses let's say a pulmonary artery pressure of 65 on echo, and you do a right heart and you find the pressure to be 75 or 55. It doesn't make a big difference in the management. That is one. Secondly, echo being very simple, non-invasive, less expensive. So people try to get away by doing this echocardiography diagnosings and treatment. So as I said, this would be then left for not as a routine test, but somebody is getting diagnosed for the first time. Before labeling him as ABC of pulmonary hypertension, I think it is important to ascertain the proper, quantitate pulmonary artery pressure and also think about the etiology related to that. And of course, it also would give you some clues related to what kind of treatment modalities to be chosen. So as I mentioned in my last slide, it is something which is probably appears a must in some cases. For follow-ups, I don't think it should be done because echo is good enough once you have the initial guidelines.
And these days, especially for pulmonary artery hypertension, we don't rely just on echo. We use a whole variety of non-invasive or partially invasive tests, work out a risk score, and then modify their treatment. As you said, sir, it is only once initially that this right heart cath is absolutely essential. So I think, that gives us a fairly clear idea of what needs to be done for these patients. The other question that I had for you is approximately, and this is a question almost everybody asks always, so I'll ask it because you've said earlier that, this is a condition where, it's underutilized. Is cost one of the factors that comes into this, why we don't utilize it that much? How cost effective is this procedure in the Indian context?
It would mean 1 day hospitalization. It would mean cath lab charges and other things. And If you use something like a Swan-Ganz or a flow-directed catheter, it would go almost to 25,000 rupees in the premium institutes, maybe a little bit less in other institutes. So for a diagnostic catheter, diagnostic procedure, this is quite a bit in Indian context, according to me.
And last question, then we let you go. I know you will want to get away. Is, can this procedure be done by a pulmonologist?
Very much so, no doubt about it, because all that you have to learn is simple techniques of intervention, the punctures and other things. Finally, a lot of things are clinical medicine. Suppose somebody there was a hypotension or a arrhythmia or this, that. These are all clinical aspects of the procedure. So I would definitely encourage all pulmonologists to learn it. And whenever you want to use it, practice it, get some support from cardiologists initially, and then be on your own. I think then you don't have to depend on cardiologists to manage this. The other suggestion is to get a cardiologist who has passed out in the last 3 years, and he will do everything for you. So that's also one way of looking at it.
That's a very good suggestion. That's what we've done. So fellows in interventional cardiology are eager for any procedure. So those doing their fellowship usually are willing to oblige anytime, day or night, whatever you want. So that's a very good suggestion. Thank you very much, Dr. Hiremath, for both your talk, the questions you've answered, and I'm sure you'll always be available for people to, ask you for your opinion on anything to do with interventions, heart transplant, and so on. So we'll let you go now. Thank you very much for your
Thank you. I'm honored. Thank you very much. Good night.
Thank you, sir. Right. I am going to turn now to Dr. Satish Govind. And Dr. Nitin, you can come in at any point on these questions, but anything you'd like to add to what what is being asked. Dr. Satish, one of the questions that has been, posed on the chat box is to do with the exact emphasis on echo diagnosis in detail. Now, I thought Dr. Nitin had already provided us great detail, but one of the problems we often have is that, for example, we depend a lot on only the pulmonary artery systolic pressure. So when you look at an echo report, that's one of the few things we look at. So what should a pulmonologist look at in an echocardiograph report? What should he focus on when he's, really looking at these reports? Can you elaborate a little for us, please?
Thank you, Dr. Murali. Coming to the question, when the echo report is looked at, it has got a lot of parameters. Therell be a lot of text in it, and sometimes many people don't know which is to be seen and which is to be given importance. So I would sort of, summarize it in so something like 4 parts. One approach is, as soon as you look at the echo report, just straight away hit the chambers and the valves. Just look at the chambers, whether it is normal sized or whether it is dilated, whether it is hypertrophied or not. That is one. And second is to look at the valves. Are the valves okay? Are they sort of leaky, or are they stenotic? So that would be the second part. So to a large extent, you would have covered on the left side as to what is happening, and also you're starting to look at what's happening on the right side in terms of the RARV dilatation. That is one. Next, I would suggest is to look at the pressures itself. So, straight away, obviously the first thing you're going to look from the pulmonology side is the pressures. So the PA pressure, that is the one which is most commonly reported, the PASP. So and then of course the right atrial pressure is the next thing which should be looking at. So once you're done with the structural and then you're done with the pressures, then you look at the function of the both the chambers. So what is the status of the RV function? What is the status of the LV function? So this would be the fourth point. And the last one, which is, I feel, a little under a sort of a scene, but has got a lot of importance, is pericardial effusion. Anytime the report mentions that there is pericardial effusion, start to connect and see whether the pericardial effusion is something related to the right heart itself, because your patient is not going to do well. They are going to sort of rapidly go downhill. So rest is all related to the other clinical issues, but I think this would be the sort of four-pronged approach I would suggest.
So I think it's very, very important. One of the last sentences, especially that you mentioned, look at it in the clinical context. So no echo should be interpreted in isolation. I think the European Society of Cardiology guidelines on pulmonary hypertension make this out very, very clearly. And if I can share my screen with the permission of the CCI, one of the things that we always look at is the flow that we are looking at. This is the initial diagnosis by echocardiography. And you can see that the echo comes very early in the diagnostic process. Immediately after the symptoms, signs, and history, which make you suspect pulmonary hypertension, you look at the echocardiographic probability. And if it is high or intermediate, you go down one path. I'm not going to go into those details. And if it's low, you consider other causes, or you follow up for the patient. So then you refer to a PH expert center. But the point I'm trying to make is echocardiography is still the starting point based on a clinical approach. The other thing we must always remember is that echocardiography has its own limitations. Okay, so very often you get a discordance between the pulmonary artery systolic pressure and the right heart catheterization pressure. Obviously, we take the right heart catheterization measurement as being the gold standard, irrespective of the fact that there are sometimes problems with that also. But by and large, RHC measured, right heart catheterization measured pressures are the gold standard. And you can see that there's a lot of variability. In fact, there was a difference of more than 10 millimeters of mercury in 48% of the patients in some studies. However, we should, once you interpret the echocardiography appropriately, okay, so this is not based only on the pulmonary artery systolic pressure, then you can get better information and you can decide whether the pulmonary artery pressures recorded at echo are likely to be true or not. And one of the cutoffs they use, and this is, I think Dr. Nitin Abhyankar has already told you, the pulmonary regurgitation, tricuspid regurgitation velocity, if it is V, 4V squared, gives you the pulmonary RV systolic pressure, to which you add the right atrial pressure, which is again a derived measurement. And from that, you calculate the pulmonary artery systolic pressure. And from that, you calculate the mean pulmonary artery pressure with the formula 0.61 into PASP, the pulmonary artery systolic pressure plus 2. This is the most widely accepted, but not necessarily the most accurate measure. So this corresponds to a pulmonary tricuspid velocity of 2.8 or less. If it is 2.8 or less, this is not likely to be pulmonary hypertension. If it is less than 2.8, but there are other echo signs, the probability is intermediate. If it is less than 3.4 and there are no other echo signs, the probability is still intermediate. But if there are other echo signs, the peak tricuspid regurgitation velocity is between 2.9 and 3.4, or as a single measure, you're just looking at the tricuspid regurgitation velocity of greater than 3.4. You don't really need other pH signs, and you look at the overall echocardiographic probability. Now, these other echo pH signs we're talking about include some of the other things that Dr. Nitin Abhyankar has already mentioned. So I'm not going to go into great detail into that, but we always will look at the risk factors, which means the clinical associations, the already just mentioned echocardiographic probability, whether it's low, intermediate, or high, and then you decide on the likelihood of pulmonary hypertension. So essentially what I'm trying to say is, when you are interpreting an echo, please look at A, the clinical suspicion, B, look at not just the pulmonary artery systolic pressure, but also look at the other echo features which support a diagnosis of pulmonary artery hypertension or pulmonary hypertension, and then go on to make a diagnosis of pulmonary hypertension and working the patient up for more than that. So, Dr. Satish, what is your approach when you are reporting a pulmonary artery, a right echocardiography for the pulmonologist? What are the things you will emphasize? Suppose we come back and ask you, we are a little confused about this. Can you explain this to us?
Dr. Murali, I think those were, the very salient points which have been brought about in the guidelines and which we should all be aware of. But unfortunately, guidelines, what is shown doesn't necessarily translate into real life scenarios where you have these reports which come to you, which don't really have this information, and that is where the real, the disconnect happens and the pain point starts. If one really looks into the background of why this neglect has happened and why this focus has not been there, is that LV has always been the big brother, and it has always garnered the attention, and all the views in echo are mainly LV focused. So that is number one. Secondly, the problem with RV has been that there has always been lack of data. So nobody sort of really has gone into extensive detail. And if you look at those of you who are more interested in echo, you would have come across some guidelines. So the 2010 guidelines had a different set of numbers, and now 2015, 2016 guidelines had a different set. Again, this has happened, the change, because of more and more data coming in. So lack of data is also sort of caused this problem. So, and the third point is more unique to India, I would say, where we are burdened with numbers, and usually the focus is always on the EF and the valves and the chambers, and beyond it, the echo person really doesn't go into it. So if you look back, I think you'll all agree that about 10-15 years back, RV was not even reported in any, most of the reports. It was never really sort of, it was, it was like an afterthought. It's only about the last 10-15 years it has come into sort of attention, and it gets the attention it deserves right now. So this is the background of how it is. And the third part is RV itself is a very difficult chamber. So to quantitate has been one of the biggest challenges, because there has been no real consensus, because there's been no data, and a very difficult chamber. So it's, that's where the sizing is. Dr. Nitin showed a lot of numbers, the technical errors, the limitations. There are a lot of problems. So that is where it puts off a lot of, the regular echo people also. So they sort of tend to sort of brush it aside, and, they just don't know which one. For example, RV size. So there's still no real consensus as to what would be the exact RV size. LV has got its definite, way of measurement, but RV doesn't have it. So we sort of pick and choose, and we sort of go by, and then again, that may not be sort of reflective also, as you rightly pointed out, in terms of the windows and other things. So again, the whole point is like RV is a very difficult chamber. So that is as far as sizing is concerned. And of course, function is even more difficult, because the RVOT has always been an issue where the volumes have never been really captured. So 3D to some extent has come close, but it's still, far away. It's not really in the real life. So we are still stuck with something which is TAPSE, which has been there for ages. So in the overall context, if you look at the parameters which are available now, it is just the 3D RVEF and the GLS which are new, but most of the parameters which we are using presently right now has been there for decades. So it is just the same thing has been sort of reworked and relooked, and you get more data, and then suddenly the the awareness and the reliability comes in. So in a very broad context, I sort of would sort of put it this way. But if you have any specific questions to each one of them, I would sort of go deeper into it.
Can I ask you a simple query? I was talking to my technician today, the person working in the echo, and they said, well, the RA volumes or the RV volume, they never estimate that because they don't have the software. So, is it that difficult to get it, or is it simply just the fact that it is not being done or asked for?
I think I would probably go for the second comment, because it is not demanded, because it is not pestered, because it is not repeatedly questioned. There is this tendency to sort of brush it aside and don't give it that importance. But I think that would be the.
She was extremely confident. Of course, I mean, she had done 1,000 ecos before me, and I was doing the third or fourth or whatever it is. But at the same time, I mean, she was extremely confident that all this is not needed. We do it indirectly. And even for that matter, R pressure, when they talked of RA pressure, they said, we look at the IVC and is it collapsible or not? And then that formula of 20, 15, 5, so it applies, and then that's enough. So where is the need of measuring RA pressure?
Yeah, I would again emphasize on that point. You really have to sort of bear down wherever who's practicing. If you have access to the echo person, I think if you repeatedly question them, repeatedly ask them why this parameter is not available, it should start appearing. Because assessing RA size, it is a matter of seconds, and it is no special view for that. It is just one caliper, one measurement. It's just few seconds, and again in the echo report, it is just one entry. That's it. RV size, same thing, same view, you get the same information. So it's not an issue at all. And even TAPSE also, you get it in the same view. So I wouldn't sort of say technique is an issue, or it takes a longer time. No, it is just that the attention is just not there. The priority is not there, I would say. So I would sort of suggest that you should keep asking for it.
I see it, the simple take home for most of people who are attending and are listening to it carefully is we have to start asking for things rather than sort of depending on what is available. Because most of the times I simply get RA and RV mildly dilated kind of a report. That's all that is written about RV. So.
Yes. That subjective approach is also there when they busily sort of in a very busy lab, they measure the LV very accurately and LA size, but the RV is all subjective. They just look at it and say subjectively RV is dilated. And similarly with the IVC, it took me a long time. Just the same thing. What earlier it was just like 5, 10, 20, 15. These were just arbitrary numbers which are being given and added. But it is only now that the collapsibility is being much more looked into, and then the guidelines are also emphasizing, and also in our sessions, scientific sessions, we are giving more and more emphasis. So there should be a little more accurate way of doing it. It should not. The subjective sort of part of it has to come down. But again, going back to it, you have to ask for it, and you have to emphasize on that.
Dr. Satish, I'm going to go to one of the questions asked by Dr. Jyoti Reshma from Kerala, Kollam. She says, sir, could you please explain the role of echo in evaluation of acute pulmonary embolism?
Acute pulmonary embolism, I think first and foremost is that it is two ways of looking at echo. So you have a patient who's come with acute symptoms, and then most likely to be hemodynamically unstable. So echo is not very good at picking up the thrombus. So you are not likely to see any clot or anything. It is just about less than 5% in a general sort of situation. In a critical care or in intensive care, your yield might be a little more, maybe around 10-15%. So that is number one as far as looking at the clot is concerned. So two ways of looking at it is you are ruling out the possibility of the right side involvement, and there's also a possibility of picking up something which is mimicking the pulmonary thromboembolism on the left side, or a pericardial effusion which you can pick up. So that is where the echo focus should be. Now, the other important point is, assuming that there is acute pulmonary thromboembolism, your focus should be to look at, there is this old one, which probably you're aware of it, that 60-60 number, where the PA systolic pressure, the PASP, derived by TR, it is usually less than 60. And then a very simple measurement, again, a Doppler measurement across the pulmonary valve, which every echo person does. A simple time caliper, again, a measurement if it is less than 60 milliseconds. So this is the so-called 60-60 rule. So if it is fits in, then you know that there is a high likelihood of this is going to be acute pulmonary thromboembolism you're going to deal with. The other important thing is look at the RV function. You know that there is, there's much talked about, much hyped. Of those of you familiar with echo, there's something called McConnell sign, but it has never really been that sensitive in terms of specific sort of wall motion where it happens sparing the apex. So the RV function is the next important thing which you should be looking at. So this is how the approach should be, the 60-60, looking at the RV function and then trying to rule out any other cause which is causing that's where the role of echo is. And of course, CT is always going to be the greatest friend in such situations.
So to add to what Dr. Satish said, since we look after quite a lot of pulmonary embolism, when you're assessing a person with pulmonary embolism, there are different stages. The first is to make the diagnosis, of course, and that, as he's just told you, the gold standard right now would be either a CT pulmonary angiogram or sometimes a VQ scan. Now, a CT pulmonary angiogram is far more easily available, so we rely on the CT pulmonary angiogram. We honestly don't waste time doing a echocardiogram to rule in or rule out a pulmonary embolism. So what you do is you go by the Wells score or the simplified Geneva score, assess the probability. If the probability is intermediate, you do a D-dimer. If the probability is very high, you push them straight into a CT pulmonary angiogram. If you have now diagnosed a pulmonary embolism, an acute pulmonary embolism, then you still use the echocardiography, and this is where it's more useful to risk stratify the patient. And a risk stratification rests on 3 layers. The first is the hemodynamic state. So the person has hemodynamic collapse, dropped his blood pressure, is in shock. Straight away, it becomes a high-risk pulmonary embolism, also known in the United States as a massive pulmonary embolism. If a person does not have this much of hemodynamic compromise and is otherwise perfectly well, it becomes a low-risk pulmonary embolism. And a low-risk pulmonary embolism, after ruling out some factors I'm going to enumerate now, can even be treated as an outpatient with anticoagulation. In between is the key group, what in America is called the submassive pulmonary embolism, and by the Europeans and the British is called, I'm leaving out the British because they've exited Europe, is what is called the intermediate risk pulmonary embolism. And this is based on factors like the echocardiogram, very importantly, does it show any stains of RV failure, RV dysfunction, and what is happening to the pulmonary pressures. Remember, in acute PE, the pulmonary pressures don't go up very much because the RV has not adapted to it, but the pulmonary pressures rise. The second important layer to look at is the biomarkers. And one of the biomarkers we use is the BNP or the pro-NT-BNP to tell you what is happening to the RV stretch. And the other is the tropi or other markers of myocardial injury, which also go up when the pulmonary embolism is severe. So based on these 3 factors, you will decide to put the patient into a high risk, intermediate risk, or low risk. And that's where echocardiography comes in extremely useful. But my recommendation is, if the patient is unstable, in the ER, you can do an echocardiography while you're waiting to shift the person for a CT pulmonary angiogram. Don't send the patient off too far away to an echo room. In order to do that, do it only in the ER while you're waiting to shift the patient. Okay, but after the pulmonary embolism is confirmed, please get an echocardiogram done. That's when it comes in extremely useful. Dr. Satish, I hope you agree with that. Please make any corrections in what I say.
I think very practical points, and you very nicely put it and classified it. I think all the points were sort of emphasized. Just to sort of go back to one point which I made earlier. So when the suspicion of acute pulmonary thromboembolism is there, but you're not very sure about it, and as you said, like you're waiting for certain sort of investigations or for some other things, echo can be used to rule out or look at any other causes which are likely to have caused that hemodynamic instability. So that is the value of echo, which has also been shown, where you end up diagnosing something else which you initially thought it was acute pulmonary thrombosis. So you use the echo for that. And as you rightly said, in the algorithm, echo comes very sort of lower down. It doesn't come at the top.
While in all other cases of pulmonary hypertension, it comes right at the top. So my colleague, Dr. Syed, he works with me. He's very interested in lung transplant as well as in pulmonary hypertension. We partner together in a lot of our PH cases. Dr. Syed has several questions to ask, and all of them are difficult questions. So I'm going to hand it straight over to you, Dr. Satish. How much contribution is from post and pre-capillary pulmonary hypertension? How much can you understand from an echo? Are you dealing with pre or post-capillary pulmonary hypertension? How do you approach this before a right heart cath is done?
Well, I in a very sort of a simple sort of way, if one has to differentiate between the pre and post, if you look at the post, usually the LA size is bigger in post, and you will have some sort of an abnormality in terms of a coronary artery disease or an LV systolic dysfunction. So this would be on the one side. And the other important thing is to look at the curvature of the septum itself, the interatrial septum. It's more likely to curve towards the right side. And this is one more point which is in favor of post-capillary. And then, more importantly, there is going to be a diastolic dysfunction findings, which is going to be sort of very key to it, especially when you have a non-valvular status. So any diastolic dysfunction, which is a grade 2 or a grade 3, you know that it is likely to be post-capillary. And the other, to some extent, is to looking at the pulmonary Doppler, the outflow sort of pattern. So you're less likely to see a notching in the pulmonary outflow Doppler. So these are sort of points which are in favor of post-capillary. On the other hand, pre-capillary, it's just the other way. So you're going to have a RARV, which is going to be dominant, it's going to be bigger. You have the interatrial septum bulging towards the left side. And you may get even RVH also. And then the notching of the pulmonary outflow Doppler is going to be more frequently seen in patients with pre-capillary. So to a large extent, echo can differentiate from both the pre and post-capillary.
Right. Dr. Syed has another question. By the way, when we use the term pre-capillary and post-capillary, this is really based on the right heart cath data. And Dr. Jagdish Hiremath has already told us what you do is you advance the pulmonary the pulmonary catheter right up till you wedge it till it can go no further. Now it's reflecting the left atrium and the left ventricular end diastolic pressure. So if it is elevated, it's above 15 millimeters of mercury, then you're dealing with a post-capillary pulmonary hypertension. If it is less than 15, you're dealing with a pre-capillary pulmonary hypertension. But it doesn't quite stop there. What you also need to look at is the pulmonary vascular resistance, which is again calculated. We won't go into that. But if you have a pulmonary vascular resistance of greater than 3 Wood units, it goes along with a significant pulmonary pre-capillary problem. While if it is less than 3 Wood units, you may not be dealing with severe pulmonary hypertension at all. So you can recognize 3 types of pulmonary hypertension: pre-capillary, post-capillary, and a combined pre- and post-capillary pulmonary hypertension. And this is how you look at the current way of assessing the different groups of pulmonary hypertension. Dr. Syed's next question is on the groups of pulmonary hypertension. To remind the audience, there are 5 groups. Group 1 is where the disease is in the pulmonary artery itself. This is called Group 1 pulmonary hypertension, or more accurately, pulmonary arterial hypertension. All the other groups not being called pulmonary arterial hypertension, but just pulmonary hypertension. Group 2 is when it's secondary to left heart disease. Group 3 is our own area where it's secondary to lung disease, hypoxia, including conditions like obstructive sleep apnea, which I'll come back to later. Group 4 is something that Dr. Hiremath referred to, chronic thromboembolic pulmonary hypertension or other obstructions to the pulmonary artery and pulmonary arterioles. And group 5 is conditions that don't fit neatly into one of these boxes. Either they have multiple causes or they have factors that are not very clearly worked out. So the grouping falls into these 5 groups. Dr. Syed asks, can we differentiate various groups of pulmonary hypertension based on echo characteristics? Dr. Satish, your...
I would sort of say it is quite a challenge. I don't think to a large extent it is possible. So let's take up the groups itself. So I will straight away go to the group 2. Group 2, I think, is the easiest one, if at all, to identify something which is there on the left side. You have a valve, or you have an issue with coronary disease, anything related to the left ventricle. And also, if there is any sort of congenitals, which you have these outflow issues, coarcters, things like that. So this would be the easiest one to say, it is going to be group 2. The next one, where to some extent it can be done, is the CTEP itself, the group 4, where you have a patient with right ventricular hypertrophy. There will be previous history of most likely a DVT or some sort of a thrombus which is coming from the deep veins, and there is going to be very high PA pressures of around 80 or beyond that. So, and you have all the other sequelae of large PA and all that. So to some extent, the group of 4 can be identified. And coming to group 1, again, where there is focus on the congenitals. So again, one can sort of try and identify to put them into group 1. But I think beyond this, it's going to be a little difficult. Group 5 especially is going to be the toughest group in terms of multifactorial and the rare ones. So just group 2 would be the easiest, just to sort of say, and then group 3, and then to some extent the congenitals. So this is what I would sort of put across.
I'm going to leave Dr. Syed's last question to the end, but Dr. Jyoti says thank you for the explanation. And she says, very interestingly, with COVID-19, we're having more and more patients with pulmonary embolism, and most of them are too hemodynamically unstable for a CT pulmonary angiogram. What would you advise then?
Yeah,
I think with the one of them, we know that there's a lot of there's a procoagulant state associated with COVID. So again, the echo itself has got its own limitations. It's the same story, the same information it's going to provide as far as COVID is concerned. The only thing that you can add to it is that you can look at the GLS, where they have some sort of cutoff where anything around a free wall strain of around 13%, the prognosis is sort of not, it sort of worsens. So I think beyond that, there's not much contributory sort of what echo can provide in a COVID situation.
GLS is global longitudinal strain.
Yeah, the global longitudinal, the speckle tracking strain, or the global longitudinal strain. So that is a newer parameter. So that is where some data has come and shown that 13%, it's usually around 20% and above. So 13% is quite adverse when it is.
Dr. Nitin, I'm going to ask you to come in on that question, please.
I think the clinical story is pretty convincing, and the D-dimer flies into thousands, and often flies about at 10,000 also. So I think that's a unique story which you have seen during the Delta. I don't think we are seeing it in Omicron anymore. I am seeing some patients going up to 800 or 1,000, but never more than that. So I think that was one thing which was so striking. That the microthrombi which are there in the circulation were causing so much rise in D-dimer. For the first time, I have seen those kind of D-dimers, and in those, last 30 years, I would say. So I think that was fairly convincing for me to do it, as well as if you really look at the ATS ERS statement, then they said we should be looking at this, and then going into a NOAC or whatever, LMWH or eventually a NOAC, going on for a good 1.5-2 months, depending on what the scenario is and what the clinical story is. I think that was I don't think we have seen this ever before. So this is only the COVID thing which we have taught this us. This is a clinical learning rather than the measurement related, because I don't think the measurements have really correlated very well with this actually.
Absolutely. And again, I'd go back to what I said earlier. If your clinical suspicion is high, the person is very hypoxic, your D-dimers are very high, an echocardiogram shows you, that the person is not in left heart failure, which sometimes happens. They go and develop myocarditis, but it's all right-sided. Then I would therapeutically anticoagulate them while we're waiting. And in any case, anybody with more advanced COVID, moderate COVID to severe COVID, even if they don't have this, we would be keeping them at least on prophylactic anticoagulation.
At least prophylactic for the time being, till we have made up our mind about what the clinical is. Basically. Because I think
I wouldn't be pushing the patient for a CTP at this point if they are hemodynamically unstable, clearly. which is, I think, what Dr. Jyoti is asking about.
Yes, absolutely. Yes, agreed.
Right. So the other question, Dr. Nitin, has been asked to you. What is the formula you mentioned regarding IVC collapse? How does it help you decide on right atrial pressures? As we've already said, it's a very inconsistent thing.
It's been iffy, if you really ask me. I mean, I'm not really a good fan of it, but then, experienced cardiologists keep on mentioning, I mean, the IVC collapse and the extent to which it's happening, and it correlates beautifully well and kind of things. And my technician seems to be directly adding 20 straight there, as long as if the IVC is not collapsing at all. So I think that I'll ask that back to Dr. Satish, what would he do in this situation?
I will go both ways in the sense like if the window is good, if the subcostal view is good, most of the times the IVC is well seen, and there's a certain technique to it wherein, if those of your hardcore echo will know that we have to put on the M mode and we have to slow down the sweep speed, etc., etc. And then you get this nice little sort of, collapse and whether there's no collapse or whatever it is. So you get a good sort of measurement. That is with the good subcostal view. But in quite a significant number, I mean, I really can't say, like maybe around 30% or so, where the subcostal is not good, that is when the problem starts. So that is when this arbitrary, this number which is, actually recommended. So the 10 is what is recommended. If you don't see a good IVC and, if you can't come to a collapsibility number, just put a number of 10. So that is one which I would say. And that is as to how we, practically that's how it works. Coming back to the IVC itself as a parameter which is variable, as you use the word iffy, I think definitely yes, there is an issue with the IVC itself. If you look at the guidelines itself, one of the reasons why the number of the TR velocities, a lot of emphasis is given on TR velocity and not on the PSP. That is one of the questions that keeps coming back every time I get into any sort of pulmonary hypertension sort of discussion as to why TR velocity is sort of focused more, not the PSP. But it's the other way around. In the echo reports, most of the time you end up getting PSP, but you don't get the TRV. So as people who read the guidelines, you are sort of surprised as to why am I not getting TRV and why am I getting PSP? But that is because the IVC itself is a derivative, it is an estimate, and then that is where things can go wrong, and the actual number of the RAP adding to the TR gradient can be variable. So that is why the guidelines say that just focus on the velocity of the TR, that itself should be good enough, and you eliminate this variability that IVC sort of collapsibility brings it. So this is the other side of it where it doesn't work well. So you can look at it both ways also.
So essentially, can I ask you a sub question on this? I mean, between TAPSE and TRV, which is better, or is there any choice there, or
TAPSE is actually to assess the RV systolic function. So the higher the TAPSE number, that means that the RV is bouncing very nicely, very good. So that is a different parameter. It is just for RV function, systolic function. IVC is to look at the pressure within the right atrium. So bigger the IVC and less likely to collapse, that the pressure in the IVC is quite going to be
more or less equal.
Yeah.
Yes.
If it's a small IVC collapsing, that means it's an underfilled, it just that's the message as far as the IVC. So it's just looking at what the RA is, the pressures are. So IVC is just a reflection of the RA pressure. It's nothing else.
So essentially, you look at two things. You look at the IVC diameter and you look at the collapsibility of the IVC, and you use those two to factor in what you think is the RA pressure. Is that right?
Yes, absolutely. Absolutely. So it is the diameter and the sizing and the, just to repeat, the collapsibility. So the more it collapses, less likely the RA pressure is going to be high.
And this is respiratory variability.
Respiratory variability.
Okay.
Yeah, so normally the word sniff is there. So it is, if you do, just tell the patient to sort of take a sniff, they just do this. So that means you're doing, looking at the collapsibility. So
is there a trick for COPD? Because almost invariably the subcostal view is missing there, the window is poor.
No, actually I would put it the other way. COPD, the subcostal is sort of slightly better. The transthoracic parasternal windows are bad. because what happens is the lungs, they expand, and they sort of fill up with air, and they sort of cover the window, whatever is there. And also what happens is it pushes the heart a little lower down also. So you actually tend to get to see much better subcostal windows in PPDs and emphysematous patients. So the other trick is, you can go a little laterally, and where the anatomy is, the IVC sort of courses in a sort of linear way. So you go a little laterally, and most of the times you do get to pick it up. But this comes with experience, and when you have difficult ones, it may not truly reflect the RA pressure, but you have a fair idea of what's happening to the IVC. Go more laterally.
The other questions that have come through, first of all, I must tell you, Dr. Jayaraman from Chennai says, wonderful discussion and update on 2D echo and RHC. So thanks to all the panelists for this. And he thanks CCI, of course. The other question I wanted to ask you, Dr. Satish, is how often do you think a pulmonologist should ask for a bubble contrast echo? Is it a must in the evaluation of a person with pulmonary hypertension to rule out shunts, both intra and extracardiac? What exactly do you do when you do a bubble contrast, and how do you interpret it?
I think it's a good question. So one is that it's a double-edged sort of test. So it can go either way, and I'll tell you why. First and foremost is a bubble contrast, I think, should be asked as much as possible, because it doesn't cost much. It's very easy to do, and you get some information immediately. So there is nothing wrong in asking for a saline bubble whenever your suspicions are high and you want to sort of rule out. So first and foremost, that is very clear. Ask for bubble contrast echo as much as possible. Now, the second thing is the point which I said is it can go both ways. It is very important that it is done in the right manner. So if it is done in an incomplete, there are a lot of limitations where a lot of, I wouldn't say limitations, lots of challenges. If it is done in the right way, it will give you some really good, if you look at the data, it's almost 100% in many of the conditions. So that is because it's been done in the right way, though the numbers are small. So what is the right way? That means like at the time that, the Valsalva is a very important trick involved in the bubble contrast, because you have to sort of make the RA pressure go up and, push the LA pressure back, and that's when the bubbles go across. Otherwise, if a weak Valsalva or a poor Valsalva, you're not going to get a, you're going to get a negative study, and then that might be false negative. And the other important thing is the bubbles itself. So many a times the technique of pushing the bubbles itself is not enough. So you need to get a good, solid right heart opacification. Only when the entire RA is filled up with bubbles, that means that it is a good bubble shoot. And the next is the Valsalva. So if you have these two sort of things going for you, the bubble contrast gives you a lot of information. And again, the last point I would make is that when it comes to intracardiac and extracardiac, we always use this 3 cardiac cycles. I mean, I would suggest to a lot of people, these are all small data which have come from small studies and very limited studies also, and somehow they have stuck on. You can even go up to 6 cycles. So even up to 6 cycles, it can still be considered as intracardiac shunt. And sometimes I've stretched it even to 8 because I've seen bubbles coming directly from the PFO. There's nothing as good as, looking at the PFO and seeing the bubbles directly coming from the pulmonary vein or from the, that is as good as, you're getting direct information. So use the cardiac cycles a little carefully, and you can push it up to 6 cycles also, and you can still say it is intracardiac. And beyond that, you start to think of extracardiac. So that would be my message as far as bubble contrast is concerned.
So essentially, you interpret it by looking at when the bubbles appear. If the bubbles appear fairly early, it is more likely to be intracardiac, and the cutoff you use is 6. And beyond that, especially beyond 8, it's more likely to be extracardiac, something like a pulmonary AV malformation, for example. Yeah. Okay. And you also like to look at where, but obviously that needs a good person doing the echo, whether it's coming across a PFO or it's coming across an ASD or a VSD shunt, or whether it's coming through the pulmonary veins when it becomes an extracardiac shunt. Is that
Yes.
right?
Yes, absolutely, absolutely. And this, especially with transesophageal echo, the pickup is much better, where you get to see the PF a little better. So whenever your suspicions are very high and the patient is sort of supportive, I think it's better to do a bubble contrast echo on T rather than TT, because the sensitivity and the pickup is much, much better. And you actually get to see the bubbles coming from the, which particular vein. You can actually localize it. You can, really look at it.
Excellent.
I have a question for Dr. Satish. Is 3D echo coming, or is it not really going to happen?
No, actually, 3D echo is very much there. Till about 4-5 years back, it was still a research tool, but the commercial software is very much there. And it has a lot of challenges because I use it. We have it in our center. But the point is that the window has to be good. If the window is not good, then the tracing, whatever, it is garbage in, garbage out sort of business. But it is very much there for commercial use, and it is sort of validated to a limited extent, though the exact number as to what is that is still the 2D sort of number cutoff is being used of 45%. And the volumes are fairly accurate. When they have compared it with CMR also, it is sort of less in terms of the CMR, but it is very much there.
Dr. Satish, one of the other questions that I had for you is, what is this diastolic stress test and what value does it provide?
Yes, I think this is something which, I've also been looking into it, and, from your team also being sort of, looked into, where you have these patients who come with the breathlessness and you're unable to put a finger onto it as to what is the cause for the breathlessness. You do the usual workup, the first and foremost is obviously the coronary artery disease. The CT, the coronary angio is normal. And then you look at a lot of other causes, and nothing is sort of being explained as to why this patient is breathless, and especially this is exertional. So as I was talking to Dr. Basha, that there is this, in the now abroad, there are these clinics, Disney of unknown origin. So they are specifically looking for these, trying to find it. So the diastolic stress test over the last couple of years is getting increasing attention. So that is the reason is there is something which you all are aware of, heart failure with preserved ejection fraction. So this is nothing but patients with heart failure with preserved ejection fraction who are sort of not overtly manifesting it, but it is happening only when they exert themselves. And when you do a resting echo, most of the parameters are within normal. So the AF is normal, the E by E prime at rest is normal, the PA pressure is normal, the LV is not dilated, everything sort of looks, except for maybe a hypertrophy will be there or LA is dilated. So this is where the diastolic stress test comes in, and they have done both invasively and non-invasively. So the focus has been on making the patient exercise. So when you exert the patient, what happens is, if there is a myocardial disease and if there is a heart failure which is there subclinically, so this will manifest. How does it manifest? There are three parameters one looks into. So the main thing is to look at the E by E prime, and then the TR itself, looking at the PASP. So if the E by E prime is normal at rest, and when you exercise the patient, usually the exercise is recommended one is bicycle. I don't have a bicycle. I do it by the exercise. I've just recently started to do it, and I'm finding information where when they exercise, and immediately within the first 1 or 2 minutes of recovery, you can get information. All you have to do is just look at the E by E prime again during that recovery phase as the heart rate is still high, and you find that the E by E prime actually goes up. And that is the first indication that there is an increased LV filling pressure. So that means your LV, the LA pressures, the LVDP, something is sort of going up and causing problems. Next is you also add to that by looking at the PASP. So if a PASP is more than 45 after the exercise, then you know that you're dealing with a patient who's got a component which is occurring at exercise. So this is something which you should keep in mind, where you have these patients complaining of breathlessness, you're unaware of how to deal with this. So definitely this is something which should be kept in mind.
And that's something I think all of us should also know about, meaning all pulmonologists know about. I mean, one of the things that, I learned quite late was that in patients with obstructive sleep apnea or any sleep disordered breathing, just as much as there is the chance of pulmonary hypertension occurring due to hypoxia during the night, far more likely is the fact that these patients have significant amounts of diastolic dysfunction. They tend to have hypertension, they tend to have sympathetic overactivity, and because of that, they end up with a lot of diastolic dysfunction. So the pulmonary hypertension in them may not be so much group 3 as much as group 2. And that's something that we find more and more often. The right heart and the left heart are linked so closely. We need to look at both the sides. And that's where diastolic dysfunction comes in. And the fact that probably heart failure with preserved ejection fraction is at least as common as heart failure with reduced ejection fraction. And it's not uncommon to get people with both heart failure with reduced ejection fraction with also a preserved ejection fraction. So they have a combined, heart failure. And the treatments, therefore, are quite different. The other question that I had for you, this is something that, our emergency physicians and our intensivists do very often, Dr. Satish, and that is do not only an echo evaluation, they also look at the lungs. We look at pleural effusions, which, the routine echo also does, but also things like the B lines, which will tell us more about the fluid within the, lung parenchyma and so on. So is it possible with this point of care ultrasound to start focusing as much in patients with breathlessness on these other issues and not just look at the echo itself, or look at the heart itself in the echo?
Yes, the point of care ultrasound has become an important tool, as you all know, and especially looking at the lung signs, there is enough data, wealth of data, saying that it is the inter and intra-observer variability is very less, and then it is reproducible, and it's very simple to do. So that is the plus, side of it. But unfortunately, I think what we don't see is that it is not being done that often to the extent where you would like to see the management being affected, in a much better way. It is still in the the protocol, the teaching curriculum of the intensivists or the critical care people, where they are focused more on that. Unfortunately, on the echo side, it is still not part of regular sort of teaching. So that is why you'll find at the most, a sonographer or an echo person giving information about pleural effusion, but beyond that, it doesn't go. But it's a great point. I think there should be more emphasis, and I would actually suggest that, as pulmonologists, you also should, take up the echo itself. There are enough these acronyms of FAST, and you have this blue
protocol.
Blue protocol. So I think it's just and the clinical value is very much there. Most importantly, I think you are going to make a difference. You yourself, being there, I think that is the most important thing. And to add to it, the industry is also, obviously it works in their favor. Also, they are also pushing it. So you are having a lot of devices that are coming in. So I would sort of say that, you should use these devices more and more, the handheld devices, the so-called ones, which are sort of are going to be very helpful. And yes, I think to answer the point, it's something which should be done more often. It is easy to do, and the value of it is there. So the lung ultrasound is something which is under and done, and which I think should be given more attention, definitely.
So I'm going to come to the last two questions, both by Dr. Ajay Lanjewar from Maharashtra. First, he asks, treatment of group 3 pulmonary hypertension, do we have to depend on all old pharmacotherapy? Are there any new breakthroughs in recent times? Dr. Nitin, you can take it, and I will come back on it also.
I think we can keep repeating ad nauseum that the treatment first is correcting the oxygenation status. Whatever is the etiology underlying has to be corrected. So if it is purely oxygen support, that has to be kept on correcting. If there is obstructive sleep apnea, we have to correct that. So whatever group 3, what is causing hypoxia, you have to correct it to your best ability. That is the first order of business. There is a drug like riociguat, which is emerging, and has help in patients, but that's again group 4. So it doesn't really come into the group 3. So I think, and then I would clinically treat some of these patients whom we perceive as disproportionate kind of a pulmonary hypertension. So they're disproportionate to the amount of hypoxia. So if I've taken care of hypoxia and I still find that they are suffering because of a very severe pulmonary hypertension, then I think I would consider treating them. Once again, I think the treatment choices are possibly, there's nothing really new as far as I imagine, because Ambry with tadalafil is possibly one of the best combinations to be starting with. There is some data on macitentan about the mortality or morbidity, mortality statistics, but then there are issues related to the side effect profile. So I think they sort of balance each other out. So I think you still come back to the Ambry tadalafil kind of a combination. But I think drugs possibly is not the right answer for group 3. Group 3 essentially is all about correcting the hypoxia more, and that possibly occupies 90% of the space, and 10% space is left for a truly disproportionate pulmonary hypertension. I hope you agree with that, and your comments also on this.
Completely agree. And how do you tell that a person has disproportionate pulmonary hypertension? As Dr. Nitin said, you find somebody who's not hypoxic. He has no business having pulmonary hypertension because of, lung disease. So then you start looking for other things. Or you find that there is lung disease, but it's not very severe. For example, the FEV1 is more than 70% predicted. The FVC in a person with interstitial lung disease is more than 60% predicted. These people don't really become hypoxic unless they have associated pulmonary hypertension, which is often due to group 1 overlapping with group 3. Those are the only patients in whom you could probably use the pulmonary vasoactive medications. One small change has come recently after what is called the INSPIRE trial, where they used inhaled treprostinil in patients with ILD. And these patients showed an improvement in various parameters, assessing, including 6-minute walk test and pulmonary pressures. And the logic is that when you inhale a pulmonary vasoactive medication, it goes to areas which are better ventilated, and therefore you actually improve VQ ratios. Whereas in other cases, when you take it systemically, you actually worsen VQ mismatch, which is already the starting point of the hypoxia.
Absolutely.
So apart from this, in all other cases, and we don't have inhaled treprostinil, we don't have any form of inhaled pulmonary vasoactive medication. So for us, at this moment in time, please don't use pulmonary vasoactive medication before you use it.
Iloprost, but not treprostinil as yet. Inhale iloprost is on its way. Absolutely.
But we don't have any evidence for that yet.
Absolutely.
Yeah, so that's the problem. The last question to both of you, if at all, and this again comes from Dr. Ajay Lanjevar, he says, if at all 2D echo has to be included in the PG program, what should be the basic expertise which can suffice? This is for a PG pulmonology program. And if someone wants to indulge later on in future practice, what is the minimum that a postgraduate training course should involve? I'll start with Dr. Satish and leave the last word with Dr. Nitin. So Dr. Satish, what would you recommend that pulmonologists should know during their training about echocardiography, and perhaps you can add about right heart catheterization?
It's now, if you look at the US, then there are many, training programs which have integrated the ultrasound, the echo as part of the curriculum. It is now, instead of carrying a stethoscope, now the reality is that they carry a handheld right now. So it is now part of it. So for the future and even the present generation, I think it is a must that if you get your hands on an ultrasound machine or echo machine, please take advantage of it and use it as much as possible. Get used to it, because it's going to be part of your practice in future. So otherwise you'll miss the bus, so to speak. The second point is what is there to learn. So of course you're not going to look at the intricacies of the strain, or you're not going to look at all the complexities of the echo. The main point is how is information which you gather from doing an echo then and there, and how is
is it going to change your treatment? So the ones which sort of really make a difference is looking at the LV function and looking at the valves, which are, these are all very easy to identify. So looking at any valvular heart disease, looking at pericardial effusion, and of course, looking at the pressure. So one can start with this. And over a period of time, I think with experience and with skill, you can sort of scale it up. I think the first and foremost is just look at the ventricular function and look at the valvular disease and to look at any pericardial issues and the pressures, and especially the IVC and the TR. I think they are the easy ones. So the focus should be on that, and later on it can be scaled up.
And I guess it need not be restricted to the PG programs. Practicing pulmonologists can also start doing it.
I'll go a little beyond that also, because if it is going to save a person's life, even a physician or a general practitioner, because it's reached a point where putting an ultrasound and on the chest or looking at an IVC, it's nothing great about it. It's just anatomical, and all you have to do is just understand some very basic information, and then you get information which you can use it. So I would go a little beyond and say that it should be pushed as much as possible, because it's going to save lives, it's going to change management, and you're going to make a difference. So I would go for it.
Okay. Dr. Nitin? Yeah, I think so totally agree with Dr. Satish. And I think, my first stint with a Doppler ever in my life was when I started doing EBUS, because that is the first exposure I had. And then today when somebody talks of a TR, and the TR velocity, I understand it because I have now understood it. So it took me so many years to reach this point in nearly 58. And I mean, just 4 years back, I had a first exposure to a Doppler, and now I can today talk with a little bit of confidence, like a student who's presenting in a seminar on 2D echo. Though I don't do it really, but I have started visiting that particular place more often. So I think it's all about taking interest and going there and spending time and trying to understand. It's not rocket science anymore, because I think most of these technologies are sort of superimposing on each other one way or the other. So if you're doing an EBUS, you start understanding a little bit of echo. If you start understanding that, you start understanding a little bit of heart related issues. So I think they are all complementary to each other, and definitely 100%. In fact, if you today say a blind pleural tapping is almost obsolete. We don't recommend it, at least in the tertiary care centers, anymore at all. Even in the secondary care centers, we encourage people to do a guided tap. So the fact that, you have to visualize, and when possible from visualizing from outside with a technology which is looking in, I think that, and a non-invasive, I think we must adapt to it. So I think these are the times where we have seen huge change. In fact, from my practice, we used to do all blind tapping. I'm sure, Murali sir, you have also done the same thing. And we have moved on to guided, and now, no more blind tappings at all. So I think that kind of a story will apply in almost every walk of the technology applications, which will involve EBUS, which will involve 2D echo, which will involve all kind of things. So I think we have to keep on adapting and keep on learning. And I think our generation is possibly the maximally learning generation, as I see it, because others are probably ready with that information.
Yeah, I totally agree with every point. I would also say that just to go back to the technology which you mentioned, the ecosystem is evolving one right now, and there is tremendous potential. I mean, there is no end to it actually. And with the AI being integrated and with the auto sort of measurements which are being in place, so life is going to be a lot more easier for the people who are going to sort of image, from my perspective, I would say, so that you get the information coming much more easier and faster and quicker, and also the access to advice. So you have any number of people who have connectivity, and if you do have a problem with an image, you can always send it to somebody, and you get your you can do it in a professional way, you can do it in a sort of a friendly way. So connectivity is a big thing, and then it's the whole the AI is going to change the whole sort of perspective of how we do it.
Yeah. So I had a couple of questions on AI for you, but we won't go there because we are running out of time. I'm going to stop by thanking both of our panelists. In fact, all three of our panelists, Dr. Jagdish, Hiremath, who left us, but gave us an excellent talk. So we've gone from something as fairly basic as echocardiography for the pulmonologist. Dr. Satish, of course, does a lot more advanced echocardiography, to invasive techniques like right heart catheterization. Remember that echo, non-invasive, non-radiation, can be repeated quite frequently, does not harm the patient, and is relatively inexpensive compared to other modalities of investigation. So I think all of us should certainly learn how to use it. The barriers between the specialties should be broken down. We should be able to go and sit down with the echo technician. If we have still doubts, go to the cardiologist doing the echo, like Dr. Satish, and say, look, I have a problem. I'm not getting, the answer I need. Can you help me with this? My experience is that they're always extremely helpful and will be able to clarify doubts for us. But the first step, I think we shouldn't go to them with every single problem. We should learn to handle some of these ourselves and reserve the more complicated issues. So somebody like Dr. Satish Govind can spend more time on the cases that really deserve it. And believe me, I've seen he takes a lot of time when the case demands it. Okay, so we don't want to occupy his time with minimally important things we can handle on our own. And I'm sure he'll be happy with that approach also. When necessary, we should probably start, and this was Dr. Syed's point, should pulmonologists take over all the investigations for the right heart? And I think there's nothing which prevents us from doing this. I know Dr. Andrew Peacock from Scotland, for example, does his own right heart caths. He's a pulmonologist. He does his own right heart caths and he's doing a lot of his own echoes when there are, sticky points that he'd like to look at. There's no reason why all of us should not do it. And I think doing it in your clinic, point of care, ultrasound, looking not only at the heart, but also looking at the pleura, looking at the chest, looking for evidence of pneumothorax, looking for B lines in the lungs, is going to transform the way we examine our patients, not only using our stethoscopes after a good focused history, but also, and this is the key point, it's going to help our patients better. We'll be able to reach our diagnoses faster. We'll be providing a better service, better care, and most importantly, saving lives. So I'll thank all of you for this opportunity to chair this session, to moderate this session, for wonderful input from both of you. And I'll leave each of you with one sentence that you'd like to close with, starting with Dr. Nitin Abhyankar.
I think, as we said with COPD, do more, walk more. So do more of whatever that you are doing. It could be an echo, it could be an EBUS, or whatever it is, and learn more. So I think do more and learn more.
We are in an exciting stage where we're learning a lot of new technologies. Dr. Nitin, the younger generation are really very fortunate that we've seen pulmonology advance so much in our professional career. Dr. Satish, last words for you.
I think we have spoken enough. So all I can say is that, I hope that this discussion is going to make an impact and have, even some percentage of it is going to change their practice. I think it has been well worth it. And we have learned a lot from each other also. And there are still so many things which we still cannot explain. These discussions are always going to be nice. So thank you, Dr. Murali. Thank you, Dr. Nitin, Dr. Vijay, and then the CCI. It's been a wonderful sort of interaction for me. And I look forward to more interactions in the future.
Thank you so much. We look forward to hearing more from you. We will always be hearing from Dr. Nitin, of course, and I hand it back to the hosts at this point.